One of the primary issues in oncology is the format of reporting. Physicians report either through their medical exam in a chart, and then somebody extracts the information from a chart. So that ends up being whispered down the lane. It's the physician interpreting what the patient said, and then the clinical research associate interpreting what the physician said from the chart and trying to then match that to what you actually ask a patient. So you're far removed from the source. The other issue is we have a standard reporting system in oncology called the Clinical Adverse Event Reporting System, which was never validated or never meant to be a comparison or a research tool. It was only meant for adverse event reporting of chemotherapy and later radiation therapy and immunotherapy, but we use it as a research tool. So people will say, you know, in this research study, here were the toxicities that were clinician reported. The problem with that is that list is hundreds of pages long. Nobody can go through that as a checklist. Also, it's never been validated. So there's a grading system from 1 to 5. 1 meaning very low level. They don't even have a 0, so you can't mark, no, they don't have it. You start with 1, which is a low level of a symptom, up to 5, which is death. So if you can't mark all of the things, and if you have to mark things on a grading system, the instrument has never been validated for research, meaning, so there's no inter-rater reliability, meaning if I rate something as a 1, do you rate something as a 1? Well, it turns out if we actually do little studies to look at that, we don't. So there's a huge disconnect, not just between the patient and the physician reporting on this adverse event reporting scale. There's a big disconnect between physician to physician reporting on this scale.